We're good. Okay. Thank you everyone for being here today. It's my pleasure to introduce our guest speaker, Ms. Didi Nelson of Mountain Pacific Quality Health, Hawaii, is here to talk with us today about working together to achieve healthcare excellence. She is the director for the organization for the last 16 years and will be presenting to us today about Hawaii's QIO, or Quality Improvement Organization's contract. Please join me in welcoming Ms. Didi Nelson.
Need the mic louder? Thank you, John. And thank you for inviting me. I feel very honored to be here today. I just so appreciate being able to speak about my passion, and that's quality improvement. We have been working together for excellence for many, many years. It is not new to Hawaii. We have a history of working together towards excellence. The first Polynesians that arrived brought with them plants with the noni, the sweet potatoes, the antioxidants that we know today that we like. That's their healing properties. They brought the chickens and the other white meat, pigs. As we grew and Kamehameha did his unification plan, the Hawaiian healers together with the Western medicine got together, and I'm sorry, I'm a little nervous, so you have to kind of excuse me. So as we grew, the Hawaiian healers and the Western medicine got together, and they shared what they knew towards excellence for the people of Hawaii. As we grew, we got the sugar plantations and were established. The pineapple plantations were established, and immigration began to come in. The Chinese began to arrive, the Japanese, the Portuguese, the Koreans, and the Filipinos, and they all brought their specific healing arts. We had the teas, we had the massages, we had acupuncture, we had Portuguese bean soup, which was a very good healing agent. And we had the good hand washing, the hygiene, and so forth. As we grew, the war years began to take over Hawaii, and we got a large military presence. Our hospitals and clinics began to flourish. It was necessary at that time for our private insurance companies to begin. Congress looked at the aging population. By now, we had gone from living from 65 years old, which was at that time old, and it's not anymore. 65 is the new 35, as we all know. So we went from 65, now we're going into being elderly into 72. And so they decided that they needed a health insurance for the aged. So Medicare came into being. Medicare was started for the aged as their insurance. When they left their jobs, there were no more insurance, and this is becoming a cost-effective role for the Medicare population, for this population. So Medicare started, and in those days, when people came in as a Medicare person to the hospital, they got to be treated until they were well. So they went into the hospital, say they had pneumonia. And it wasn't until the pneumonia was gone and they were walking around and doing a little bit of exercise, then they got to go home. So they may have been in the hospital for 2 weeks. Well, Congress looked at this and decided, oh, this is costing us a lot of money. So the diagnosis-related groups were established at that time in 1966, 67. What they did was they put together these same diagnoses or similar diagnoses into groups. So if you had pneumonia and you also had diabetes, that would be in a group together, and the hospital would get paid a certain amount of money, and we're told now you can only stay in the hospital for 5 days. Instead of the 10 that was taking, they cut that down to, say, 5. So that's how the diagnosis-related groups came in. And Congress instituted a pilot program, the Professional Service Review Organizations at that time, to look at why the patients were going into the hospitals. Were they being admitted appropriately? Was this the right place for them to be admitted? The medications that they were having, was it appropriate? Are they getting a timeliness in their care? That program, that pilot program, worked so well that they instituted the peer review organizations. So the peer review organizations were established, and there were 53 of them for 50 states plus the District of Columbia, the Virgin Islands, and the Puerto Rico. And this was all about cost control. How do we control our cost, our utilization of services? As we grew and that program flourished, this was a 3-year contract for these 53 contracts throughout the United States. And it was working really well. So that was the first. Every contract period was called a scope of work. And that was the first scope of work. That continued through 3 scopes of work. And finally, at the 4th scope of work, Congress looked at it and said, you know, we've kind of got it. Our hospitals have got it. The utilization of services has gone down. We are controlling some of the costs, but they're still not controlled enough to where we're making money or saving money. And as our population, we're looking at our population, and they're growing, and we're growing older. So let's tweak it a little bit, and so quality came into view. So now the peer review organizations are looking at quality as well as utilization. As quality took up precedence, the name changed from peer review organizations to quality improvement organizations. They asked us to look at what diagnoses, what diseases were causing people to go into the hospitals. So throughout the nation, we did a research. And it was astounding that throughout the nation, there were these 5 same or similar diagnoses: congestive heart failure, acute myocardial infarction, pneumonia, diabetes, or the reduction of surgical site infections that were causing people to be admitted to the hospitals. So the mission of the QIO program is to have effectiveness, efficiency, economy, and quality. These are services provided to the Medicare population. In 1996, Mountain Pacific Quality Health was established in Hawaii. We're a Montana-based program. They were awarded the contract for Hawaii, and then the Hawaii contract also includes the territories of American Samoa, Guam, and the Commonwealth of the Northern Mariana Islands. We're a nonprofit organization. We're physician-sponsored, which means that physicians throughout Hawaii and the territories sign an affidavit saying that they believe in quality and they will practice good quality improvement for their patients. Our vision is the best quality of care is provided to every patient we serve every time. Our funding comes from the Medicare and Medicaid Services, or CMS, as you well know, state contracts, and private contracts. So where are we today? We started in 1996. Actually, we started in 1965, doing the quality improvement, doing the utilization review. In 2011, Dr. Don Berwick says, research shows that there are still too many lives that shouldn't be lost, conditions that shouldn't develop, mistakes that shouldn't be made, and costs that shouldn't be breaking our economy. There are high demands on our providers today in 2012. We ask them to do more with less, do it better, do it faster, increase quality, increase patient focus, use evidence-based medicine, and use computer technology. Oh, and by the way, we're going to decrease your reimbursement rates. And your computers are going to cost you not $5,000, but $50,000. But the three broad aims that this has brought for the whole nation, and this is what Hawaii is striving for: better health care, better health for people and communities, affordable care through lowering costs by improvement. 2011, the quality improvement organizations were given yet another contract. And this contract is the same as we've been doing for the last 10 years, with a little difference. We're now going out into the communities. We are not only doing the beneficiary-centered care, we're improving individual patient care, we're integrating the populations, we're bringing the patients and the communities together, the provider types together. We're improving health care for populations by prevention. In our beneficiary and family-centered care, we're doing the quality of care reviews. They're still very much alive and part of our work. We're doing reviews for beneficiaries who request that they call us and they say, I think I've been asked to leave the hospital too soon. I still don't feel well, or I have a fever. And so we do an investigation in that. We're working towards reducing the healthcare-associated infections. The central line bloodstream infections, the catheter-associated infections, Colostrum difficile infections, which is a bacteria that the elderly gets in their intestines, and it spreads. It's diarrhea, and it can be very fatal to our elderly population. We're looking to reduce surgical site infections as well. Oahu hospitals, just Oahu hospitals in 2010 spent $14.3 million on infections, on hospital-acquired conditions such as the falls or the traumas, the catheter-associated tract infections, pressure ulcers. Our rural hospitals, which is our neighbor island hospitals, and our critical access hospitals spent in 2010 $2.1 million. We have these costs brought to us by the Hawaii Health Information Corporation. They are, excuse me, they give us our data so that we can keep tabs on where we are in Hawaii. Improving individual health care is another piece of this. Reduction, we are doing this in the nursing homes and the long-term care facilities. Reduction in pressure ulcers, reduction in physical restraints, consistent assignment. We're finding that as the nurses or the nurses' aides get consistent assignment and they're assigned to the same residents daily, that resident becomes part of their family, so they can understand what is going on. They can see the changes. We have seen a lot of improvement in the patient-focused care because of it. And these are the others: the reducing drug events, reducing preventable harm, and so forth. Our hospital-based, value-based purchasing is our hospital reporting. And let me go to the next slide first, then I'll come back. This is out of order a little bit. Quality improvement and reporting. We provide technical assistance to the hospitals and the critical access hospitals and the PPS hospitals, the acute hospitals, for reporting. They report, let's see, these clinical processes and care measures. These are such as, did they give an antibiotic prior to surgery, 1 hour prior to the incision of surgery? Yes or no? If a patient came in with an AMI or a heart attack, did they give the right medications? If a patient is having a general surgery, did they give a prophylactic so that the patient will not get a blood clot? So there are 70% of these clinical measures are put towards their end of the fiscal year reimbursement. So the hospitals are able to get at least 2% more reimbursement if they show that they are doing quality improvement activities and that they are meeting these measures. 30% of that is patient experience. Did the doctor communicate with you? Did the nurse communicate with you? Was your pain under control? This is a new piece for us this time on the 10th scope of work. It's the care transitioning between providers, called care transitions. We're looking to reduce readmissions following a hospitalization by 20% in 3 years. Hawaii at the present time is at 15% readmission rate, which is very good compared to the nation at 25%. We're looking to establish provider communities that work together, and this is the first time. I've been in this field for now 20 years, and this is the first time that the different settings are coming together and sitting on a table like what you have here, and they're talking about their processes and how can we improve the process. They're not looking at what is it in it for them. They're looking at it, how can we help the patient and the patient's family. This is unprecedented, and I am just so proud of our Hawaii providers and the way they are working together. We are working with physicians and their staff to improve their prevention measures, to improve the flu immunization, the pneumococcal immunization, to improve how the cholesterol rates are for the adults, and the colorectal screening. If you're 50 and over, I ask you to please get a screening, a colorectal screening. Improve breast cancer screening. I ask ladies, everywhere I go, did you get your breast cancer? Oh no, it hurts too much. No, it's a little uncomfortable, but it can save your life, and your life is worth it. If you're a smoker, stop smoking. That's not good for you. We're also working with physicians to promote electronic health records, to promote these prevention measures where the physicians can look at their computers when a patient comes in and just screen on their screens and see when a patient has had their last flu shot or when they've had their last colorectal screening. And in this way, improving the care. So we see these communities all working together to improve care. 2011, CMS established an Innovation Center for Patient Care, and this is part of the Affordable Care Act. Some of the money, $500 million, went into establishing healthcare, different innovative healthcare ways. So this Innovation Center was established. This center funded the National Hospital Associations to do quality. Prior to this, the hospital associations were not into the quality arena. They are now into the quality arena. Our own Hawaii Healthcare Association established the quality improvement area. They hired Susan Young, Dr. Susan Young, to head their quality. She is excellent. The Department of Health got some of the money to reduce healthcare infections as well. We worked with them to lower the MRSA rates in Hawaii and to write a, I guess you call it, it's a law now that the hospitals have to report their MRSA rates and some of the infection rates through the NHSN, through CDC. So everybody's working together. Once again, all of us are working towards excellence for Hawaii. Partnership for Patients was established in 2011. Better care, lower costs. They came up with the Hospital Engagement Networks, the QIO contract, the same as the QIO contracts. They're doing the same work, except they're doing it with the younger population. The QIO contracts are focused on the elderly population, and now the Hospital Engagement Networks are focused on the younger population. So together, we are working for all of Hawaii. We have established an affinity group between Department of Health, Healthcare Association, HHIC, which is the Information Corporation, and the QIOs to work with our 12 PPS hospitals and 9 critical access hospitals to move our work forward. So this is what it looks like from the hospital standpoint. They have all of us coming towards them, asking for data, asking to do quality improvement initiatives. We have the QIO, we have the Flex grants, we have NHSN, which is the CDC. The Joint Commission comes in, DOH, and then they have their own corporate reporting. They have the Partnership for Patients. So they're saying, whoa, wait a minute. All of you coming to us, they're frustrated. So we're working together to lessen the burden on the hospitals and not to duplicate efforts. So we're asking them to just put their data in one area where we can pull it from that area. And as we form, say, for the care transitions, we are taking care of the communities, and the Hawaii Hospital Associations are going into the hospitals and doing the one-on-one training. So that's how we're not duplicating efforts, we're enhancing each other's work. So we are working together towards excellence with the help of the Affordable Care Act that came out and the monies that have been poured into Hawaii. We are making a difference. But we cannot make a difference for ourselves. We all can make a difference. I ask everywhere I go, my goal is to see Hawaii as the leader in healthcare. I hope that someday when I'm listening to CNN, it'll say, the state that gives the best health care is Hawaii. That's our goal. Thank you very much for inviting me. Are there any questions? I either bored you to death or I covered it well.
How many QIOs are there in the United States?
There are 53 QIO contracts.
Like 53 regions, then it's all divided.
Yeah, well, we're under regions. We're private. We're actually private companies that have the contract with CMS. And so we're under different regions. For Hawaii, we're under the region 10 as far as the QIO goes. But as far as hospitals and the nursing homes, they're under region 9. So we work together with region 10 and region 9, working together to make sure that whatever the needs of the hospitals are, the QIOs will meet that need as far as quality improvement.
I have a question.
Sure.
You gave the national comparison data for readmission rate. What about the hospital-acquired infections? Do you have any data comparable at the national level?
You know, that we do have data, but the data was so old that I didn't bring it. We are pulling, what happened was the database changed, and so they are reorganizing the data, and I can send that to you as soon as we get them. Yeah. But we are very, actually, according to the old data, we look really good. The CLAPSI, we were, Dr. Della Lynn, I don't know if you know Dr. Della Lynn. She's an anesthesiologist with Queens Medical Center, and she is very involved in quality. So she took on with John Hopkins, together with John Hopkins and Michigan State, brought in what they call the CUSP program. It's a checklist program where physicians, surgeons basically, and nurses go through a checklist before they put in a catheter, a central line. It goes right into your veins. And they lowered our rates. We're at 25% central line infections, and we are now at 0.05%. So we are really making strides in that area. Sue, you have a question?
How large is your staff now?
In our Hawaii staff, we have 10 of us here. We have some staff that work out of our Montana office. All of our reviews, the beneficiary patient-centered reviews, that section comes out of our Montana office. So we have 4 states in our, we have the QIO contracts for Alaska, Hawaii, Wyoming, and Montana. Montana is our headquarters. But our board and our CEO feels very keenly about local representation in every state. So every state has an office, and we work directly with the providers in our state. And we are, most of us are here, have been born and raised and cultivated here in Hawaii. And the staff that we do have either have lived here for many, many years. So we're very familiar with our state and our culture.
Your measurement indicators are set by Medicare, right? Or CMS?
Yes.
And then so you establish the provider groups to work towards how you're going to address and overcome or
Right.
meet those indicators. Is there ever data on the county level that's released, or is it just grouped together with the state and it just is released by?
It's a state level. If you want any specific what the hospitals are doing
What just says a county? I don't want an individual.
at the county,
Yeah.
we haven't done the county, but I could ask our analyst if they could pull a county. The county would be, of course, the islands, the different islands, and we do have data regarding the different islands, especially on the care transition piece, on the readmissions for care transitions. On the HAIs, that's a little difficult to get because we haven't done as a state reporting on those. We get those out of the Hospital Compare. Have you ever heard of hospitalcompare.com where you can go in? So we could pull that off of that computer.
Thank you. You're gonna follow up.
Okay. Thank you very much.